Good afternoon, everyone, and welcome back to the Recovery Science Echo brought to you by the Peer Recovery Innovation Network at the Center for Substance Use Training and Telementoring, CSTAT. We are excited to host this Echo on this new platform to provide a seamless experience to all our learners. Welcome. My name is Shreya Prasanna, and I will be facilitating our discussion today. A few quick housekeeping notes before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, please click on the speech bubble icon on the navigation bar at the bottom of your window. We encourage everyone to join by video, especially for the discussion portion in the latter half of the session. That said, regardless of how you've shown up here, we are just as happy you're here to learn alongside us. We are recording these sessions for later distribution. Anything listed in the chat will not be shared on those recordings. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. You can also use the emotions menu in the bottom right of your Zoom screen to raise your hand and indicate you have a comment or a question to share. You can also use the chat to share your perspective. There are a lot of us in this space, so please keep your comments brief to allow others a chance to share as well. And finally, please note that no protected health information is allowed in either the chat or our discussions. Towards the end of the session, our wonderful ID support, Karen, will be sending out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to refine and shape these sessions to address your priorities, and it allows you to access free continuing education credits. All participants filling out the survey will be automatically entered into a drawing for a $30 Walmart gift card. Our didactic today is on digital interventions for recovery services and will be presented by William Nardi. Following that, he will also share a research project that is in progress. We will start with the introductions, followed by didactics, announcements, project discussion, a presentation, and discussion. Thank you all again for joining us today. These sessions are what we make of them. We encourage all of you to share your perspectives in today's conversation. And with that, we will start with some introductions. Cheryl.
Hi, everybody. My name is Cheryl Pacapelli. I am a hub member, a person in long-term recovery for 35 years, and the project director for the facilitating organization for peer recovery support services in New Hampshire. So welcome, everybody. So glad to have Bill here today.
Thank you so much, Cheryl. Emily.
Hi, I'm Emily Hennessy. I'm with the Recovery Research Institute at Massachusetts General Hospital, and I'm delighted to be here today, also a hub member.
Thank you so much. Sierra.
Hi, everyone. I'm Sierra Castedo de Martel. I'm one of the hub members. I'm a person in long-term recovery. I'm also an assistant research scientist at Chestnut Health Systems Lighthouse Institute and based in Detroit, Michigan.
Thank you so much for joining us today. Daniela.
Hi all, I'm the program manager for the Peer Recovery Innovation Network. Yeah, so good to see you all.
Thank you so much. William. Nardi. You're muted. We can't hear you.
Can you hear me now?
Yes.
There we go. Okay, you're getting a little bit closer. Hey everybody, I'm Bill. I'm a PhD student at Brown University. I work with Dr. Justin Brewer. I'm also a person in recovery as well, and excited to be here today and hear what you think about the work we're doing. So,
thank you so much. Andrea Hebler.
Hi, everyone. My name is Andrea Helder, and I'm one of the program coordinators here at CSTEP. Welcome, everyone.
Thank you. And with that, we will get started with our didactics. You can take it away whenever you're ready, William.
okay. Welcome, everybody. I'm so excited to have you here and to present the research we've been doing. First of all, I want to thank Cheryl for inviting me here. It's just so good to see you again. Thank you for having me. Also, Andrea, Kirsten, and Daniela for all your patience in getting this ready. There was a lot of emails back and forth, so I appreciate you. And I want to lead with a disclaimer, just We're going to talk today about a very specific mobile intervention, one called unwinding anxiety, and sort of the next stage of that, the mind shift digital recovery model. Apps are not for everybody, so I would encourage you to think through in your own practice or with the folks you're working with. It really depends on different people's comfort with technology and your comfort with technology in your practice. And so keeping that in mind as we talk through this, the hope is that this will be approachable for as many people as possible. But I'm really excited to hear about any sort of limitations or thoughts you might have in terms of clinical implementation for the mobile applications. Next slide. Thank you so much. Disclosure today. I think this is standard language for the ECHO. I wasn't totally familiar, but all speakers and members of the planning committee have no relevant financial relationships with the commercial interest to disclose, and the views and opinions expressed by the participants and speakers attending the ECHO sessions are solely their opinions and do not reflect the official position or policy of UT Health San Antonio. So next slide. So the three goals today, and they're big ones, and I'm going to miss things, and we'll talk through as much as I can, are to explore the potential for digital interventions to enhance co-occurring treatment for anxiety and substance use, identify the role of interoceptive awareness and reinforcement learning in digital therapeutics, and then explore the collaborative science that we've been doing with Cheryl and other folks across the country. So next slide. Thank you. So anxiety and substance use co-occur pretty regularly. It's something that a lot of you probably know. These estimates are a little low. So the more recent ones that I've seen, 29.5 million folks have indicated an alcohol use disorder in the past year, and 24 million illicit drug use. 19.1% of adults have said that they, in the United States, have said they've had anxiety in the last year. Why is this important? Because when anxiety and substance use are co-occurring, they affect treatment direction, they affect higher risk for return to substances, polysubstance use, as well as lower treatment retention. And what we know about the work is that fewer than 12% of patients get the comprehensive care they need for substance use and co-occurring anxiety. Next slide. So really, another mobile app? Some of you might be asking this question right now, and I think that's a pretty valid question. There are estimates indicate over 350,000 health apps on the market right now, and anywhere from 10 to 20,000 mental health or substance use mobile applications. These range from guided applications led by a trained therapist or clinician, as well as self-directed mobile applications, and that's what we'll be talking a little bit more about today. Why does this matter? Because of those 10 to 20,000 applications, very few have actually been tested in research and clinical trials. So there's a lot out there to sort of sift through for folks who are interested in incorporating digital therapeutics into their clinical practice or into their recovery services. A couple of places that I can recommend. One Mind Cyber Guide offers a really great overview of evidence-based applications, and also there's the Organization for the Review of Care and Health Applications, or ORCA, so they can help folks navigate. But in one systematic review, 179 anxiety and depression apps were identified. Only 3% of those were tested. And in another more recent systematic review, thinking of all the substance use mobile applications out there, they only identified 30 that were tested. And of those, a lot of them were guided. The self-directed has even less evidence associated with it, so fewer studies. Next slide. So research constantly talks about how mobile applications can overcome the barriers to existing care for folks, but the implementation of those is really a difficulty for folks. And so we sought to evaluate a existing anxiety-facing application for folks with anxiety and substance use. This application is called the Unwinding Anxiety Program. You can find it in your app store. The app consists of video lessons, a linear progression through different modules. It has expert monitored community support. So there's a community call as well as a sort of blog type community. There are emotional check-ins. So folks are asked sort of, how are you feeling right now? And then provided with a short mindfulness practice. And then different exercises. So these include stress tests or which involve getting into the interoceptive experience of stress, as well as worry meters. So looking at the understanding of sort of worry and anxiety and how that plays out in your day-to-day life. And then folks have the option to journal within the app and get feedback from different folks. So unwinding anxiety is different from classical psychological treatment, and it really focuses on understanding this 3 gears approach, looking at rethinking trigger behavior reward. And so folks are, through all of these different features and through the core modules, encouraged to start to understand their relationship with anxiety and think about anxiety as a mental habit, as a process that you go through. And so in first gear, folks recognize their habituated loops. So recognize the trigger behavior reward, which is really familiar for a lot of folks. In second gear, they're encouraged to engage in something called disenchantment, or dropping into the physiological experience of what they're going through. So dropping into how it actually feels to have anxiety right now. What does anxiety feel like? Does it feel like tightness in your chest or constriction in your shoulders? And then third gear is this process of sort of stepping out of that and looking at the bigger, better offer. We talk about different health behaviors that might be the bigger, better offer, but folks are encouraged to look at more intrinsic rewards that go along with that. So things like curiosity and awareness and kindness can be sort of intrinsic rewards. And how is this different from other apps? A lot of the apps that exist on the market are looking at sort of a cognitive behavioral based approach, which focuses more on cue exposure, where unwinding anxiety differs, and we'll talk about it in the next slide. It's really looking at that moment of craving and anxiety and settling into that, as opposed to engaging in experiential avoidance. So an example for one of the folks that went through the program, through the research study, was he actually started dropping into the physical experience of when he came back from smoking pot and seeing that that it was just making his anxiety worse. And so seeing that, okay, this is the moment when I engaged in the behavior, whatever the trigger might have been. And the trigger is less important in this model than the behavior and the result, because we're really focused on understanding those pieces. And so looking at, all right, what did I get from this? Was my anxiety got higher? I can drop into that interoceptive experience of that. And we think about reward reprocessing here. So one of the big pieces in the unwinding anxiety program and in the subsequent programs is that folks are encouraged to drop into their physical experience. So not the story that you're telling yourself, but the actual physical experience of the body. And what we found over time with eating and with smoking cessation, and what we're hoping to find with substance use, is that helps to recalibrate the reward value associated with the particular behavior at an unconscious level. So as opposed to using willpower to stop yourself from doing something, you actually drop into that, and you can ride that particular piece out and then reprogram the unconscious reward value associated with the behavior over time, leading to extinction. So next slide. So again, thinking about how reinforcement learning plays into this, a lot of classical approaches that are available on app stores are looking at cue exposure limitations, so the positive cue or the negative cue, trying to get rid of those particular cues, or looking at substitution strategies between craving and substance use, and thinking about sort of, okay, what can we do? And those are all completely valid and needed for a lot of folks. I know it's been important for me and for a lot of the folks that I work with. But what if we could disconnect that link between craving and substance use? What if we could act on the positive affect and the craving? So Thinking about this in the context of anxiety, we had a participant who spoke to us about how, I am my own trigger. I carry the anxiety with me. So it doesn't really matter where I go. And so thinking about it from that, if we think about anxiety, anxiety can be its own trigger. So you have the feeling, we define anxiety as sort of a feeling of impending doom or dread, and how that goes through, and then worry as those thoughts that come up from that, trying to plan and think through. And then the result can be just more anxiety, and that can build up over time. And so what do? The cue exposure doesn't necessarily work. Substitution strategies might work. And so the 3 gears method that we propose, actually, you can drop into that moment of anxiety, investigate it using curiosity, and sort of land back out using some of the tools in the app. Okay, next slide. So the only way that I know how to understand whether this is going to work is to ask the folks that are out in the community as you use it, and give it a shot. And so we conducted what's called a convergent parallel mixed method study. This is collecting quantitative survey data as well as app usage data at the same time as collecting qualitative data or interview data. And so what we did was we asked folks to use the app. We recruited 48 folks, and they were asked to use the app. And then we conducted a series of 3 in-depth interviews with them over the first 6 weeks using the app, asking them about their experience with it, any issues that they had with it, and thinking through, what they wanted to add to it. Is this even something that could be useful for folks with substance use and anxiety? The study recruited 3 primary substance use treatment groups, thinking about pharmacotherapy, peer or 12-step based programs, smart recovery, and one-to-one psychotherapy. And the way that we asked folks about that was we looked at what an individual believed was their primary means of treatment, as opposed to sort of assigning folks, because there were individuals who said that 12-step recovery was their primary means of treatment, who also saw a one-to-one therapist. But it was really about trying to see how the app worked with the treatment that they most ascribed to. The primary aim was to assess usability and acceptability. And we also we explored some potential outcomes for future research. So looking at emotional regulation, interoceptive awareness, mindfulness. And okay, next slide. So we had 23 folks go through the study. What we found was quantitatively, there were reductions in the Brief Addiction Monitor subscale of substance use, as well as an increase in protective factors. We also saw a decrease in craving as measured by the Brief Addiction Monitor, and anxiety and worry. Again, this was a single arm study, so we can't ascribe those reductions to the actual intervention, but it was promising to see these changes. And then we ran generalized linear models to look at changes in emotional regulation and self-awareness, as well as different interoceptive indicators, and found that when controlling for relevant covariates, emotional regulation, self-regulation, body awareness, all reduced at the 2-month post-intervention mark. One of the most interesting sort of practical pieces is this you saw this before in a slide, but you'll see the X's crossed out on different features, was understanding what folks were actually using. And so, we had no idea what they would be interested in. And so the weekly expert calls, very few people went to. The journaling, very few people used. The community support, very few people used. And then there's a question mark over the exercises. So these exercises are, again, there's a stress test, which encourages folks to understand the interoceptive experience of stress, exploring things like, okay, what side of the body do you feel this on? And how does it rate from a 1 to 10 scale? And then suggesting different practices to engage in, to a worry tool. And then also there were standard mindfulness practices you might see in one of the 2,500 mindfulness apps, or you can find online somewhere. Things like body scans and loving kindness practice and resting in awareness. And so these ranged from 3 minutes to 20 minutes. And those were almost completely not used. On average, folks use those about 6 times in the course of the 2-month study. And why that's really interesting is that when we looked at the qualitative evidence, we found that the most important pieces for folks were these in-the-moment check-ins, these sort of like dropping in for just a second. We call it short moments many times, and checking in with yourself and looking through your day. And it could be prompted by the app, and it also could not be prompted by the app. And that's something I'll come back to in a little bit that was really interesting. But the other piece was that folks were integrating practices into their day-to-day life. So they might drink their coffee mindfully in the morning. They might walk to work mindfully. And so the classical model for a lot of mindfulness-based interventions is to think about these like longer standard practices. And what we're seeing here for a lot of folks, especially earlier on in treatment, is it might be most effective to think more about how can we incorporate these short moments many times throughout the day to affect emotional regulation and the self-regulation, and look at that. Okay, next slide. So this is a quote from one of the participants. This particular individual was 22 years old. She was working with marijuana, and throughout the study, she didn't actually stop smoking, but she did notice, and this is one of the key pieces. This is a good example of first gear and working with first gear and mapping out the habit loop, as well as a little bit of second gear and disenchantment. Is over time, she started to see that, okay, when I smoke pot, I just get more anxious. I smoke pot because I'm anxious. And then when I do it, I just get more anxious. And so she actually started dropping into the physical experience of anxiety. And you can see here, she cut down on the smoking and also vaping, and was working on that. But this is a good example of a lot of folks were, they may not have stopped, and we never encouraged folks to actually stop any substances. They were encouraged to come back and talk to us at any point in time. But there was this sort of growing awareness of the effect, like the reasons why folks were engaging with the substances and how it wasn't matching up with what they were hoping for, and then dropping into the physical experience of that to start to decouple that relationship. So next slide. And then this is another individual in the study, 37-year-old polysubstance use. He was cutting back down on benzodiazepines and going through withdrawal. And he used the program. It was really, really heartbreaking, but also really, I was so happy he had the tools to work with. He worked in an area where he couldn't have his phone with him. And so throughout the day, he would practice when he was going through a particular bout of anxiety or physical pain. He would actually use the practices to drop into that. And you can see in the quote, he talks about becoming more accepting of what he was going through and being able to work through that and hold it. I can't put his whole transcript on here, and I wish I could. But he talked a lot about sort of how important it's been to drop into the physical experience, to use things like the body scan and the stress test in order to ride these cravings out. So next slide. So key takeaways from the research was that anxiety-facing app can be useful. There were particular components of it that were helpful for folks, but more was needed for the complexity of substance use. Experiential education was important for early treatment. So the ecological tools seem to be more important in the qualitative work than the actual like learning in the modules. So that was really interesting to understand and led to these questions about like, okay, what is the active ingredient in these apps if it's not sort of psychoeducation? Definitely needed customization for substance use. So they wanted craving specific tools. They were looking for peer mentorship. And they also were asking for specific community features. So one of the reasons why we found that folks didn't engage with the anxiety community was they were worried about sharing their experience on there. For the few folks that did, they did find reassurance on there and folks that they could relate to. But there was this barrier to engaging with the community because it was like, I don't trust these people. I don't really know who anybody is. And also some digital social anxiety around that. Folks wanted more education on the brain, how the medications they were taking were working with their brain, not just pharmacotherapy for substance use, but also how do antidepressants work, and how is that working in my recovery right now, and the neurological underpinnings that one of the benefits of this program is that it tends to take complicated neuroscientific concepts and break them down at a level that folks can understand. So you really understand how to be a mechanic of your own mind and how it works. And it left this question wide open for sort of, there's probably specific features in the application that are driving changes in craving and substance use, and that future work was needed. So next slide. And that's it. Thank you so much, everybody.
Thank you so much, William. This was a wonderful presentation. I will open up the floor for any questions or comments from our community here today. Cheryl?
Thanks. I was trying to find out how to raise my hand. Hi, Bill. Thank you so
Cheryl.
much for presenting on this today. I know I had helped early on trying to recruit some people, and although not part of the trial, I, had the ability to use the app, and I found it really interesting that the things that I found valuable were X'd out, not X'd out, the question mark. So I loved the exercises and the body scans, and those are things I still use today, not using the tool. So I thought that was kind of interesting for my own research as to why that was. But I think in using it, I thought there was a lot of value in understanding the science behind anxiety. And that really helped me. So I hope that, you keep up with this research and we keep narrowing it down. So thank you.
Yeah, no, thank you, Cheryl. And that was one piece in the qualitative feedback for folks. Was a really important part was that neuroscience was broken down so they could start to understand how their brain actually worked and map those habit loops out. So it's cool to hear that you could relate to that as well.
And in a really cool, not scientific way, like in cartoon figure-y kind of things. Like I thought that was perfect for me. So I'll be quiet. There's other people with their hands up.
There are animations in the app, and a lot of folks like the animations. So they do help folks understand the complicated concepts that are going on. So
Thank you, Cheryl. Lindsay?
Yeah, I was kind of follow up on that, and I wonder if, somebody who has been in this field a little bit longer and understands these concepts a little bit better would get more of the use of the short thing, the thing she was talking about, because when just as a person who had never experienced anything like that, what if I came into it and I thought like a body scan, that sounds stupid, I don't want to do it. Like that would just be my first thought, right? As somebody who didn't know anything about it until you really, and then also not having somebody to guide me through it, like I don't know, to me that would be like iffy if I didn't know anything about what that meant.
yeah, and Lindsay, especially when you think about like, okay, I'm a single parent. I have 2 kids. I'm working 2 jobs. I gotta walk the dog, and you want me to sit down for 10 minutes and when do I have, talk to me about when I have 10 minutes, when I'm going to bed. Like, so a lot of folks, there was that barrier where it was like, what is this thing? And why do you want me to spend time with my body? Like, but also it was, it was just more approachable for a lot of folks to do something like feet awareness or like visual awareness. We had one individual who talked about, being in outpatient treatment and being ready to sort of strangle the people that he was in his group with. And he just did the visual awareness check-in without the app and was like looking out the window, and it calmed him down. He was able to actually re-engage with it. But yeah, so it tends to be more approachable for folks to think about it in short moments many times, for sure.
Thank you so much. Yeah. Did anybody have any questions?
There's one in the chat. that
Yeah.
says, what do you
Yeah.
think the application, oops, I lost it. Maybe.
Yeah, I can read that out. It's from Danielle. What do you think the future applications are for app-based recovery services? Should we explore these type of technologies replacing in-person services?
A great question, Danielle. And there's no easy answer. So depending on a person's needs, the severity of their symptoms, their other co-occurring conditions, I think app-based interventions are another tool in the toolbox. For some folks, the program that I'm about to ask you all what you think might be enough. With the social support, but I will say that it's really about being discerning and understanding sort of, and that's what the participant needs, what the client needs, what you can offer, and maybe what the holes are. So, thinking about some outpatient treatments, they're doing the absolute best they can to provide services for substance use care, get folks hooked up with housing. And so when you have somebody come in with severe anxiety, they may not be able to offer the comprehensive services. So maybe an evidence-based mobile application that they could take with them while they were in outpatient might be helpful in that situation. But should it replace comprehensive substance use care? I'm not sure. So it really depends on the app. There's also models that folks are looking at now called blended interventions or blended digital care, which is the inclusion of like a clinician as well as a mobile application. It's like almost flipped classroom approach. And so I wish I could give you like a absolutely, but I think it's really case specific and the services that you offer and the services that your folks need. But one of the pieces that probably is really important is that we get these digital applications more evidence-based and easier to understand and connect with so that folks on the ground can say, okay, I do think an app would be appropriate here. Here are my options, and here's how I'm going to use it, as opposed to what we have now, which is just this sprawling system where you're like, okay, I'm going to throw a dart at the wall and maybe I'll land on an app that works. So
That's great. Yeah, thank you so much. I think that was a great comment, and we will move on to the next part of our session. Thank you so much again, William, and we'll come back to you to discuss your research project. Karen, if you could please bring up the announcements from BVEL. Thank you. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via a team of experts. To request technical assistance, please complete an online request form and we'll be pleased to help you. And we can drop the link in the chat. Next slide, please. Do you have a research or evaluation related work in progress that you would like to receive feedback on? CSTAT offers you the opportunity to present a research or evaluation related work in progress and receive feedback from our community of experts. You do not need to prepare a formal presentation. We will provide you a case form to fill out to assist with your case presentation. Please email us at cstat@uvisca.edu. Next slide. Please join us for our next Recovery Science Echo on December 18th. And with that, we will move on to the research project presentation. Karen, if you could please bring up William's slides, and you can take it away, William, whenever you're ready.
I'm very excited to get your feedback about this. So we had all this information. We also had a lot of lived experience with folks with our previous mobile applications. Unwinding anxiety isn't the only one. There's a craving to quit application as well. There was on smoking cessation and another application called Eat Right Now. And there were a ton of folks. Some of them are on this call, which I'm so glad to see you all. It's nice to see friendly faces in the audience. Thinking through, okay, what can we do to optimize what we already know and the 3 gears for folks with substance use? And then what did folks actually tell us? So this is that moment of looking at, the 60 qualitative interviews, the pre-post evaluations, the digital log data that we have, how many times folks use different pieces. And so out of that and out of years of Dr. Brewer sort of working with folks with substance use and brainstorming this came the MindShift digital care model. This is a blended care program that includes peer mentorship, which was a big piece of folks' feedback in the preliminary research was, if you're going to offer this to folks with substance use, you really need to have someone there to help them sort of navigate how to use the gears in their daily life, troubleshoot anything that comes up for them. So a peer mentor is not a peer support specialist. It's a guide through the program. It's not sort of a guide to larger services. Folks also have access to emergency support. So for example, there's a craving tool in this program where folks are asked to investigate cravings, understand the results of cravings, and hopefully become disenchanted with substance use through that understanding of, okay, how does it actually feel to drop into the financial repercussions of me getting high? How does it feel to disappoint my partner, to have cheated on my partner? How does it feel to be hungover again? How does it feel to disappoint my family and to have missed work? What does that actually feel like in my body? And then map that out. But if a craving gets too high, there is an emergency button in the app where folks have access to SAMHSA's 24-hour hotline and other sort of recommended services or practices within the app. There are weekly community meetings on Thursdays at 12 o'clock, which we would love to see any of you at. There's also a social media community. So one of the things folks came through with on the previous app was that it was more of sort of a Reddit blog type piece where they were learning things from other folks, but they were like, why isn't this like more user friendly where I can like post things and change my name? So it got modified in this new mobile application. And one of the things I'm most proud of as a researcher is we also incorporated this seemingly small feature in there where folks are asked to check in before they post anything. So you can't just sort of like virally post, you have to drop into your experience and say, okay, how am I doing right now before I put that up on there, whatever's going on in my day. There's the mobile application, which I'll show a picture of in the next slide. Again, this consists of a craving tool, a habit mapper. There are a series of meditation practices as well, a community. And then one of the pieces that we found the Unwinding Anxiety program was a linear model progression over time. And so folks, they started at module 1, and then they went to module 28. A couple of things happened there. One is we had days attached to each module, and as folks fell behind, it became a barrier for them to engage with the app. They were like, I'm already this far behind, or I feel like shit because I didn't get this done. And so they stopped using the mobile application. The other piece was that not everything aligned with the goals that they needed in that particular moment. And so one of the things that MindShift does really well is that there are these core modules that outline the specific the gears and sort of the specific theory underlying the program. Then there are what are called Core Plus modules that dive a little bit more in to each one of those concepts. And then there's a series of additional sort of topic-specific modules that can be customized for each participant's health goals, and hopefully with the assistance of a peer mentor. And so if you're struggling with depression right off the bat, you can do a series of depression modules. And if you're interested in how you might be able to use the mind shift method in conjunction with 12-step recovery, you can go to the 12-step recovery modules and see how we've talked about the program sort of being outlined. Also, cost was a barrier. The Unwinding Anxiety app is not a nonprofit. It is a pay service application. The MindShift is a nonprofit, so the app is free and it will continue to be free. Hopefully all the services will be. So looking at that, folks, so this was a lot of people's expertise went into developing the MindShift digital care model. And then additionally, we were able to take the research that we conducted before and inform the development of that for this. But the question still is outstanding. We have all these different pieces in here. How is this going to be effective for folks, or what are the active ingredients? And so next slide. Thank you. So there's a lot here. One of them is just the MindShift app. This is, you can see the Addiction Reimagined is one of the modules, and then the weekly recovery meeting link, as well as mapping out your habit loops and the craving helper. So that's the one where folks can document their cravings. And then this other piece here, I put this in, I was trying to figure out how to sort of talk through with folks. We are interested in understanding, so there's a lot here. We're planning on putting in an R61, R33, which is a phased research grant looking at sort of innovation and exploring the most efficient and scalable features in the application that accomplish the most amount of reductions in anxiety and substance use, and then looking at testing that in a factorial design study. And what that means is there'll be a series of different groups of folks who are assigned to different features and to look at the effects of those features on anxiety and substance use. And so, for example, one of the pieces is we're looking at testing in the preliminary phases, okay, what are the modules that are linked to the most significant reductions in anxiety and substance use? And how can we recommend those as a progression through the program, and then compare that to a self-directed approach where folks can kind of just pick whichever modules they want. And with the ecological features, we have the craving tool, as well as the habit mapper and a few others on the way, and plus the meditations, and thinking about, okay, what particular features are linked to the most significant reductions in anxiety and substance use, and can we take the noise out, the other features that aren't linked to that, and create a direction through the app where they get just the most effective features, and then compare that to a group that gets everything and see how they do. And then looking at this peer mentorship component, which we're still developing, and that'll be in the preliminary phases of the R61, is sort of developing and training the peer mentors, but looking at a mentor trajectory through the program where folks receive a peer mentor versus sort of another self-directed program. And then we were on the fence about this one, but one of the key things that sort of came up in the qualitative feedback from folks was the push notifications. Although folks didn't always log into the app to do the thing, they were a reminder for folks to do the practices. So, which is really interesting in and of itself, because quantitatively we wouldn't know that they were doing the practices if they hadn't told us that. But so there is this indication that's sort of like reminders throughout the day. Although we might not see that in digital log data, we could see changes over time, just because it might be a reminder for them to do a practice or to check in with themselves or to ground in the moment throughout the day. So the plan is to apply for this particular grant and test the MindShift digital care model to find out what are the active ingredients, and what's the most efficient and scalable way to bring that to different substance use treatment centers. So with that, I think I'm hopefully right on time, and I'm gonna stop talking. So
Well, thank you so much, William. I will open up the floor for any questions or comments.
I had kind of just a clarifying question, William, if you don't mind. So, regarding that table with the 12 different essentially group allocations, kind of a preliminary piece is figuring out the optimization, right? Like which ones are most associated with outcomes. So it seems like you'd almost need to do a pre-study of those first to then be able to allocate. Is that, and like, what are you thinking in terms of sample size and things like that?
We were looking at 50 in the R61 phase to do a pre-post evaluation and then test looking at running a series of generalized linear models to test what the most effective components are on anxiety and substance use. There's also some discussion around like using weighted effect sizes to look at what might be included in the next part in the R33 phase. But it's actually still an open question on like, how do we talk about efficiency most? So any suggestions, Emily, would be great. So.
Yeah, well, and maybe just one more follow-up question, because I think so. I've been doing work with kind of a recovery app in a recovery high school setting to see how it can help the recovery high school better support young people that are in recovery. And so working with them has provided us with kind of this unique opportunity. But I was just wondering, like, are you thinking you would recruit from like RCCs or RCOs primarily to kind of help embed it within what they're already doing as an additional support, or like just recruit like across a bunch of communities? Or sorry if I missed that, but I was just thinking that where you're sampling from could drive some of, how you think about framing it for stakeholders.
No, it's a great question. At the moment, it's open, so in the preliminary study, we recruited from partnerships with Cheryl and with Harbor Care, with Groups to Recover Together. And so folks, it was a requirement for the acceptability and feasibility study that folks be connected with treatment. But that's one of the outstanding questions that we have is, can the Mindshift digital care model be effective for folks who aren't connected with any sort of formal treatment? For example, our folks in 12-step recovery, will this be helpful for them without a guide? So we haven't put any restrictions on sort of where they're recruited from or if they're connected to care, but it is an open question, and I'm totally up for any thoughts on that as well. So
yeah, I guess one thought I had related to that is like you might have the best outcomes if you start with those groups that are already set up to support folks in recovery, right? Like, and then you could see in the best case scenario when it's implemented as part of a long-standing network and collaboration, this is what happens. And then you would think about, okay, well, how would we maybe shift or disseminate to kind of the broader community of folks? So it would be like, seeing you might get the strongest effect size there, strongest linkage, but then you could use that to inform kind of a broader approach, which is one idea I had. I think there's obviously a lot of directions you could go in there.
No, it's a great idea. We did see in the acceptability and usability study, the two groups that had sort of the longest engagement as well as the most significant effects were folks on pharmacotherapy and then the peer support group. And so there's this question of, when we're thinking about scalability, should we be thinking about scalability within a particular treatment group, or again, in the broader piece? So I'm glad you said that, and I'm going to be thinking about it now until we put it in February. So.
Thank you. Any additional questions or comments for William?
I had maybe, sorry, I don't want to dominate the conversation, but I did have maybe one question for William, but also Cheryl. Like, Cheryl, with your experience, like what do you think about kind of bringing it into an RCC setting and having it be like focused there first as a test of, I'll let you talk.
Yeah, so that's interesting. When I talked to Bill about this, way back in the beginning, there were a couple of certain groups of people he wanted to engage, right? So people who are on medication-assisted treatment. And I work at an organization that provides that, yet I couldn't get the clinicians within there to really buy into, like, just offer this to your clients. No, they don't have to do it, but just give them the option. And there were so many barriers to that, right? Like, just give them a piece of paper. And then within the RCCs, they are always battling competing priorities of, like, my guy needs housing. I don't have time to get him on this app, kind of a thing, right? So out of that, when trying to help recruit, was recruiting my friends that I knew fit into the boxes, right? And they had an unbelievable experience using the app. So I would say that I think it would be great in the RCC setting, right? Someone just coming in early in recovery as part of their recovery plan, but that partnership would have to be developed in the beginning, right? Like, we partner on writing, you guys do all the writing, the researcher, but like, we're listed in the grant application that we are going to refer these people and this population to you for this reason. And I think you would get much more buy-in. The other place, Recovery High School, I think is a great idea, right? They take their phones to bed with them, right? Perfect. Like, if you're going to use social media, use it to help your recovery. So I think that's a great avenue. And the other place I would think is a great place to recruit is through recovery houses, right? So as part of the initial intake is signing you up for this app for as long as you're here with us, right? And there could be, the whole house is signed up. So group meetings within the app and things like that. I think there's huge value in those places. But I think, my experience with trying to recruit after, like, the study was already up and running was more difficult than I thought it was going to be, especially when I was going to people who I trusted and respected saying, I am using it and it is working. Like, this is not some fly by night thing I want you to do. Like, this has huge value. I was amazed. Like, Bill, because I shared it with you, like, I was going through huge anxiety at that time when he called, right? So that's an intervention we can talk about on a different Recovery Science Echo. And he's like, oh, well, why don't I give you access to it? And it was amazing. Like, just change. I still use the things I learned in the app. So those would be my places to look. But I would also say we need to do it up front. Like, these 10 recovery houses, these recovery high schools, Emily, that you have access to, would be where I would try to recruit from.
I'm going to be calling you, Cheryl. So, you already know.
Got it.
But
I'll hook you up. So, but one of the questions that we had earlier, Bill, and I think you had it on your slide, but I didn't hear you say the words, was your intent is to have this app be a free app somehow, right?
Yeah.
So I think that will, make a lot of difference too in people who maybe aren't engaged in treatment, right? Because I think that population gets overlooked too. So how do we engage them? How do we even find them? That we know that they're out there doing different kinds of recovery pathways, but how do you engage that group to offer them this service is another question. So.
Well, that's the hope. I mean, is the cost of the unwinding anxiety program was definitely preventative for a lot of folks. They got so any folks that went through the research study got free access to the app for the rest of their life. So that was covered. But yeah, it came up for a few folks when they went through and were like, I would have to pay this much for this. I'm not doing that. So
Yeah, that, I remember, so I'm glad to see that. And somebody put in the chat, prison settings where they have personal tablets. In New Mexico, they do. And so there's another contact for you to reach out to. That could be an
thank you, Danielle. Yeah.
interesting population to engage with.
That sounds exciting, and we are excited to see how this is going to move forward and progress. Thank you again, Bill, for bringing this didactics to us and sharing your research project with us. Cheryl, if you could please help summarize today's session for our
Oh,
learners.
sure. I feel like I monopolized today's session, but Bill, I want to thank you for talking about, the first part of your research study with the unwinding anxiety app, and really looking forward to see this next mind shift app when it comes out, and hope that you will come back here to present to us again, even when you're in the recruitment phase, because it looks like there's a lot of people that would be interesting in helping to recruit for this. So I so much appreciate having you here. It was wonderful. And I look forward to the next steps in this. So thanks.
Thank you so much, Cheryl. And thank you again, Will, for your presentations. And thank you all again for joining today's Echo. As a reminder, please complete the post-session survey using the link in the chat. If you would like to share a research project or a work in progress, please do email the BWell Texas team at cstat@utisca.edu. We look forward to seeing you at our next session on Wednesday, December 18th at 12 noon Central. Have a wonderful rest of your day. Thank you so much.